This video is about doctor-patient communication. Let us first talk about communication theory. The communication model consists of a source who sends the message through a channel to the receiver, who will receive it and send a feedback to the source. The source needs to know who the receivers are and what kind of message is suitable for them or him. The message must be relevant and understood. The channel must be relevant and credible. The receiver is most receptive to messages that specifically target his or her interests and values. Feedback is an indispensable part of communication. Noise that might hinder communication could be physical, psychological, language, or non-verbal distractions. The key to communication is that if there is any breakdown anywhere in the communication process, communication doesn't occur. Some truth to remember. The patient is certainly very frightened. The patient thinks it is more serious than you. Illness is frightening, but understanding what is going on helps you and the patient. Taking a history is a method of controlling what the patient says. Example: a 35-year-old lady with nodular goiter, her history taking revealed, married with no children, she noticed the swelling 6 months ago, she went to her family doctor 3 months ago, thyroid function tests were borderline, no family history of thyroid disease, and no symptoms referable to the thyroid gland. Her possible thoughts and feelings: she is almost certainly frightened. Hospitals mean pain and death boxes with a funny smell. Doctors are frightening. Their association with life and death. They are dominant, powerful figures. They do not say too much, and what they say is difficult to understand. Her concerns: she has a lumpy enlargement. To her it is cancer, until proved otherwise. Her aunt died of cancer in the throat. She had lumps in her neck. Her aunt's doctor lied to her. Treatment was horrible and ineffective. She knows treatment is radioactive. She desperately wants children. Operations are terrifying and could go wrong. An example of doctor communication. Well, multinodular goiter is a difficult area, and probably the best is to do nothing if you accept the clinical deformity. We could use thyroxine replacement, but its success is only 10 to 20%. The real worry for you is cancer, isn't it? Cancer is not really a problem. Studies didn't find any in a 15-year follow-up of this sort of goiter. Your thyroid tests were borderline high. We would repeat tests. If higher, we will treat you with radioactive iodine. If not successful, then the next step will be operation. What do you think this patient's feelings were on her way home? What might she say to her husband? Would she come back for iodine 131 treatment? An example of doctor-centered behavior. Good morning, Miss Arthur. Your GP says you seem to have a problem with your thyroid gland. Have you lost weight? Miss Arthur, no. Any hot flushes? No. Feeling tired or slowed up? Maybe a little. Bowels are okay, not constipated? Not really, doctor. I was wondering. I think I should examine you. Mrs. Arthur's agenda not figured in the conversation. An example of patient-centered style. Good morning, Mrs. Arthur. Your GP says you have a problem with your thyroid gland. Tell me about it. Miss Arthur, I first noticed the swelling a few months ago, but I didn't do anything about it for a while. Why not? Hoped it will go away while feeling the worst. The worst? Cancer. What else? That's frightening. Do you still think it may be cancer? Well, yes, but I am hoping you would be able to tell me, doctor. The patient agenda figured high. The doctor has not started on his agenda. An ideal doctor lies in the middle, changing his behavior to adapt to needs of the patient and the situation. Now, we will discuss communication styles. Medical authority. Power or authority. Patients expect and often want powerful doctors who has reassuring authority, capable of reducing anxiety. Authority is divided into three parts: sapiential, moral, and charismatic. Sapiential authority can be defined as the power to be heard based on knowledge or experience. Controlled information increases the doctor's power. Many doctors are uneasy with knowledgeable, inquisitive patients. Such patients lessen the doctor's control. Moral authority derived from the Hippocratic Credo. Societies generally revere doctors and see their behavior as socially tight and good, and to direct patients to their own good. Many doctors are afraid of losing control and exposing too much of their patients' pain and fear. Charismatic authority. This is the most difficult of the three. It is similar to the definition of magic. Doctors can increase their charismatic power by white coats, attached staff, large desks with big chair, certificates on the wall, computers, and so on. The problem with medical authority is that it doesn't increase patient understanding. This style of communication doesn't motivate the doctor, but is supposed to make patients do what is good for them. The sad fact is that they often do not. Types of patients. The health belief model. It has 5 elements. People's interest in their health varies enormously. Considering a specific health problem, people think differently and how likely they will be affected. Patients vary on how dire they believe the consequences of a contracted illness and what happened if left untreated. Patients weigh up the advantages and disadvantages of following up a particular course of actions. Patients' beliefs do not exist pre-packaged. Locus of control. A person's belief system is strongly influenced by race, culture, religion, and its immediate society. We can divide it into 3 types of people: the internal controller, the external controller, and the powerful others. The internal controller. This type of person believes that fundamentally they are in charge of their own future health. In other words, what happens to their health is the result of their own actions. As far as communication is concerned, this type of person likes explanations, dialogue, and Socratic discourse. They want to be involved in decisions about their health, and they want to know. If the medical explanations are convincing, they will accept them. The external controller. This character is the opposite to internal controller. They do not believe they have any control over their health. An external controller is not keen on Socratic dialogue. They want to be told what to do and then to ignore the advice or not, as the case may be. They are not interested in involvement. The powerful others. This type is quite different from the others. They do not believe they are in control of their health. They believe doctors are. Strategies for persuading them to take more responsibility of their own health are firmly resisted. They are happy with authoritative doctors, not easily educated. If their ideas conflict with their doctors, they will not follow the doctor's advice. Influencing locus of control. The good thing about locus of control is that it can be influenced. Locus of control in most people is a tendency, not a fixed aspect of their personality. Patients require different styles of communication depending on their locus of control. Doctors must explore their patient's agenda and talk to them accordingly. What you need to achieve in a consultation. There are 5 tasks. Discover the reason for a patient's attendance. Define the clinical problems. Address the patient's problems. Explain the problem to the patient and make effective use of the consultation. Discover reason for patient's attendance. Listen to the patients describing the symptoms. The best way is to let the patient talk for a while uninterrupted. Look for cues, verbal and non-verbal. Don't start on your agenda too soon. Doctors make hypotheses very early in the consultation. All your energies are channeled into proving that hypothesis. Obtain relevant social and occupational information. Do this at the beginning and establish the effect of illness on work or human life. Explore the patient's health understanding. If you let him talk for a while, some of his understanding will be revealed. You might get a clue to his locus of control. Define the clinical problems. Obtain additional information about clinical symptoms or medical history. Assess the condition of the patient by physical examination. The examination you choose would be the one likely to confirm or refute your hypothesis. As the more experienced you become, the more hypotheses you will be able to generate. Make a working diagnosis. Address the patient's problems. Assess the severity of the problem. You will have to divide your patient's problem into different degrees of severity. Choose an appropriate form of management. Involve the patient in the management plan to the appropriate extent. Management options should be shared with patients, and where appropriate, the patient should make the choice. Explain the problem to the patient. Share your findings with the patient. Tailor the explanation to the needs of the patient. A common medical fault is to cloud explanations with technical medical jargon incomprehensible to your patient. Ensure that explanation is understood and accepted. Explain your diagnosis, your shared management plan, and side effects. What you are trying to achieve is shared understanding. How to make effective use of the consultation. Make efficient use of resources. Time. It's not the length that is important. A minute of 10 is responsible to achieve a shared management understanding. Investigation. Other health professionals. Prescribing. It's extremely important to establish an effective relationship with the patient. You can achieve this by effective use of interpersonal skills, empathizing, eye contact, use of touch. It will be very important if you could give opportunistic health promotion advice. Select the appropriate moment to give such advice. Linking lifestyle advice to a current illness can be effective. We conclude that the general skills for good interpersonal communication are: listen with genuine interest, actively encourage them to talk, show understanding and empathy. Thank you.